Hi everybody, thank you very much for staying on for this afternoon and our story that we'd like to share with you. So we both work at the Robert Jones and Agnes Hunt Orthopaedic Hospital and we are here to be brave, open, honest with you about our journey and this is our journey through our fall from grace regarding infection prevention and control at the hospital, and then our rise back to success over a period of time. There are parts of the journey that you will probably recognise from your own trust issues that you may have had with estates and facilities, with clinical practice, with engagement, with ownership of IPC. And we thought what we would do today is try and share some of our journey with you, because this is the sort of thing that we would like to have known at the beginning of our journey. Leadership, this is an anonymous quotation, but leadership is about asking the right questions. And we found over our journey that while we had lots of methods of assurance and compliance, we weren't asking the right questions. So when we became under scrutiny, which we'll talk a little bit more about over the next few slides, we found ourselves wanting for those questions. So a little bit about the trust itself. We are a specialist orthopaedic hospital. We have around 150 beds at any time given our activity, which you can imagine fluctuates throughout the week depending on our elective patient lists. We offer a range of services including paediatrics, outpatients, rheumatology, physiotherapy, and we are also the Midlands Centre for Spinal Injuries, where we consider our highest infection risks to be, and that is due to our patients' length of stay within the trust, the use of invasive devices, and also prior admissions to higher care areas where they may have multi-drug resistant organisms. And just to expand on the last point and what I've alluded to already, our low levels of infection that we had prior to this point had been something for us to celebrate. We were nationally recognised. We achieved all of our healthcare associated infection targets. We believed that our internal governance processes were robust and that we were underneath the benchmark spend for cleaning. So across both infection prevention and control estates and facilities or governance arrangements, we were comfortably reassured that we were achieving and doing well in everything we needed to.
So on to what happened. In reality, we had 3 outbreaks of MRSA on our spinal injuries unit over a 12-month period. And as you can imagine, this attracted quite a bit of attention of NHS England, who visited the site and found both cleanliness and IPC practice issues on the unit. Attendance at trust outbreak meetings led the NHSE team to conclude that there was insufficient ownership of the issue. Even when we gave assurance, it was not being provided by the role that they expected it. The IPC team were doing IPC and cleaning was being done by the cleaners. And more worryingly, NHSE lacked assurance that the trust knew who was responsible for cleaning important items. Shop floor teams were often giving conflicting answers on question, or they were responding with answers like, I'm not sure, followed, even worse really, by, and I don't know how to find out. This initial oversight, we have to admit, led to defensiveness. We stood by our individual assurance and we referenced the many accepted barriers that I'm sure we're all used to. We didn't want to hear the issues being raised. We wanted to use the financial barriers and the operational barriers as a cover, and our teams retreated into themselves. We became very guarded as individual teams. And now onto the fridge. That fridge. Regardless of any cleaning issues that we had, any staff incompetencies, any process reviews that we were asked to complete, it was actually a fridge that broke. There was the straw that broke the camel's back. It was a fridge that was not on the spinal injuries unit. It was not on a ward with an outbreak. It was a broken fridge that just needed replacing. But on re-inspection, some months later, following a nice green tick that we'd reported on an action plan, the broken fridge was still there. And for us, this was a perfect example of two critical issues. We worked in silos. The ward manager had requested the new fridge, so felt that it wasn't their issue anymore. Action complete, tick. We measured reassurance rather than assurance. So if the fridge had been requested, the action was surely complete. That job done. But ultimately, we really needed to reframe how we work together and what our understanding of IPC and assurance was for RJH.
So a little bit about how this made us feel. So before describing our approach, it's important to take note of some of the personal reflections of the team at the time. And I'm sure many of us here will relate to when we say it didn't matter how hard we tried, we take our failings personally. So the defensiveness that Sian's mentioned was felt by every single member of the team, because I should have done better, I should have known about this. Why wasn't that fridge replaced? And the wards and departments felt very isolated, they felt singled out, and more importantly, and all the IPC team members on this floor today will be able to relate to this, that they felt that IPC were scrutinising them and that they were being picked on by the IPC team. The IPC team felt responsible because what had we done? What had we not done? How had we not supported? What could we have done differently? Did we have the right processes and policies in place? So how could we have done so badly? How could we have failed? The estates and facilities team felt blamed. They felt they had a lack of direction on what they should have been doing. There were no clear processes as what needed to be prioritised, and we had lists upon lists upon lists. All the teams were asked to provide detailed assurance reports on our actions and improvements by NHSE, and our internal governance systems resulted in increased scrutiny. There were special committees and assurance meetings that were held on a regular basis, and yet there seemed to be a lack of understanding about where ownership of this whole system lay.
As with many journeys, although we're hopefully near the end to talk to you today, it hasn't really been smooth sailing, and there were many false starts to us making these improvements. So external support was provided to us, but it wasn't always welcomed, and often external support lacks the understanding of trust culture and how things work at your individual trust. As Sam mentioned, the scrutiny was absolutely extreme and it was exhausting. It really meant that morale from top to bottom was absolutely non-existent for some months, really. At this point, accountability still sat with the key IPC working group members. External assessors actually commented to say that you're telling us the right thing, but the wrong person in the room is telling us it. From an operational team's perspective, we were still at this point standing by our barriers. There was a lot of we can't change that, or we've always done it that way, and I'm sure there are many in the room that could have that on a t-shirt, realistically. We've always done it that way. But even when those barriers are removed and both time and money became not a problem to us, would you believe, lack of cohesion really led to discord within teams, and it wasn't really a collaborative approach, so to speak, at this point. Clinical teams were displaced out of their ward or department with absolutely no notice. The estates teams were charged with refurbishments, significant refurbishments, with absolutely no lead time at all. Short-term fixes like bringing in contract cleaners acted as a sticking plaster more than anything, like a little magic wand that solved the problem today. And what we really found from a facilities perspective is post these significant refurbishments, the cleaning time was absolutely non-existent. So we had instances with contract cleaners cleaning plaster dust off floors at 3 a.m. and we were serving patients breakfast in their bed at 8 a.m. the following day. There was really just no understanding that processes are important, that respect for subject matter specialists is important, and sometimes taking things step by step rather than rushing in is really, really important.
Collaboration and leadership. So how did we move forward? Board level recognition of the need to prioritise infection prevention and control in all disciplines. Our ward that had an outbreak became, we have an outbreak on this ward, and that was a key message to support the level of ownership that was required. IPC leadership and subject matter expert respect was prioritised by the board as well. We developed the IPC working group, so we had key influential players around the table. We focused on what we could do, what we could achieve, and what we think we might be able to do based on our defined limitations. We had fact versus story. We had visibility. We went out onto the wards. We looked around ourselves. We asked the teams what they felt was going wrong, what was going well, where they had issues. Did they have an issue trying to replace the fridge or the broken macerator? And what could we do as a team to have estates and facilities with us to say, this macerator is broken, how can we get this fixed? And the proper answers at the time, we can get this done for you by the end of the week, but I'm going to need you to use the macerator in another ward. Well, yes, we can do that. And we had the level of responsibility and accountability at the right time, at the right level for us to be able to all engage with this. It did require strong leadership, and that was to ensure delivery. We had an action plan, and at one point we had over 150 actions on that. But each action had an executive board member leading on it that we could approach to say, we have an issue with this. Can you help us get there? Can you help us remove any obstacles? And the working group in the action plan promoted local ownership. So instead of IPC being delivered by the IPC team, IPC was delivered by everybody, by the clinical staff, by estates and facilities, by our cleaning technicians, by executives. We had our medical director down cleaning a commode, and he knew how to disassemble it and put it back together again. We also had AHP involvement. We've got a very big physio department, as we already talked about, and where prior to infection control had always been a sort of nurse's problem, and a nurse's issue, we were able to engage with our AHP colleagues, and they came on that improvement journey with us, especially as their gymnasium became under scrutiny from NHSE at a subsequent visit, and then they went through that same journey that we'd all been through for the rest of the hospital. Feedback from the event, from NHSE's visit with our AHPs, was really, really positive, because now there was recognition that we were not there to scrutinise, but actually we were there to offer support. So we could support the teams to understand, to learn, to understand how important infection prevention and control was, and that every single member of the team had an important part to play with delivery of IPC.
As we've mentioned a couple of times, for RJH, the Infection Prevention and Control and Cleanliness Working Group became, and remains to this day, the key to our success. The group has organisational respect and authority, and that respect comes from resolving problems and delivering outcomes in a collegiate and professional manner. In practice, what that means for us is that regardless of the issue, whether it's in an outbreak, an internal review, or an external audit, no matter the subject, it becomes our problem and therefore our solution to make. We take the time at that group to consider what a problem looks from each stakeholder's perspective, and I think that really promotes that level of respect within teams. A great example of that would be a hole in the bay wall that we had a picture on a few slides earlier. To IPC colleagues, that hole is an infection risk. To the facilities team, it's an area we can't clean, and it's going to bring down our star rating, and someone's going to ask us about that. For our estates colleagues, it's an area we're not going to be able to get access to, it's money we're going to need to spend, where are we going to pull that money from? To the manager of the ward, it's a problem that they can't solve on their own, and they really need our support to be able to drive those improvements. And finally, but crucially most importantly, to the patient, that hole in that wall might be a concern that the ward is falling apart, the ward's dirty, that we don't have care for our environment. By taking this approach where we promote wholesale accountability and personal investment in the resolution, and we take the time to listen to others' perspectives, we're able to drive those improvements, and we actually drive them really quickly. The group itself has created a space where all members feel safe to raise a problem that they may not know or be able to solve alone. And that's really important. And critically, they need to have confidence that they will gain the support from colleagues rather than criticism, which we can tend to do. We also give the same space at that group to celebrate when problems have been overcome, to listen to success stories or listen to things that have been replicated from one ward or department to another, and to celebrate those. And finally, just to note that that group embraces now challenges to assurance rather than shying away and becoming defensive, because we have that clear goal, and that goal for everybody is, how can we make this safe?
In conclusion, that's our picture of our therapies area afterwards. The work that went on that cannot be underestimated. This was about new floors, new ceilings, new lights. And I think what was clear about all of this and what's evidenced today is the collaboration that we pushed for and that we achieved. The fact that this is a joint IPC team and estates and facilities presentation, I think, evidences that. The other thing is that any journey to change is possible. We've proved it. We moved from NHSE's oversight framework to achieving exemplar status for cleanliness in our hospital within 24 months. And we are really proud of what we've achieved. We would also like to extend an invitation to any of you to ask us any questions about our journey. We will be open and transparent. We will tell you what it was like for us, what we did, what the successes we had, what our challenges were, and what our failures were. And it's a word that we don't like to often use in the NHS anymore, but we know we've all failed at some point. But the important part is that we learned from it. We worked out what we could do from a positive stance. Happy to take any questions now, and also happy to invite anybody who's interested to come and visit us. We are very rural. We are on the Shropshire-Welsh border, in deepest, darkest Wales, Shropshire, Telford and Wrekin, but our open invitation is extended to everybody today. Thank you.